the role of T cells in fighting cancer, and that's for real. Whatever you saw is a real-time thing that you saw, and the cancer cells look like those cells that you saw, and these are really granules, and we can do that. Actually, we can do it in our lab upstairs as well. That's part of my research as well, being a cellular immunologist. So I just want you to focus and see, again, the theme is the same. We will have different aspects of cancer immunology. So today's lecture, I hope that you know how an immune response to a cancer takes place. So I'm going to go about the cellular and molecular responses. That's going to be the major goal. And I'll also talk about the concept. I think you must have realized by now that cancer should be considered as non-self. So cancer should not be considered as self. So if your mechanisms of differentiating between self and non-self fail, so obviously you would lose the fight to the cancer. And also remember that cancer will also mimic and like a graft from outside. So like a transplantation, if there's a graft from outside, the immune system sees it differently. So if you understand the basic mechanism, it will be easy for you to understand what may go wrong. And this is also important that we need to find out the immune response to cancer. How are we going to use immune response for diagnosis, for surveillance, and for prophylaxis and therapy? Just a recap from what you hopefully remember from your pathophysiology, that when we say a cancer cell, so cancer cell has some of the characteristics, like one of the characteristics they have is that they're out of control. And they basically stimulate their own growth, and they don't want to die by apoptosis, and they come up with own blood supply, and sometimes they move from the primary site of cancer, like a breast cancer can move to lungs, liver, brain, bones, and so on and so forth. This is called metastasis. And then again, since they're out of control, you have a difficulty in using a therapy to control them. But the most important thing that I will discuss today is that how our immune system fails to fight them. Okay? And before I go in detail, you must have seen me doing over and over again. I keep on saying it. You don't need to know it. But still, I think it's good for you to start looking at intracellular signaling pathway, because by the end of the day, regardless of whether I ask you or do not ask you, you need to know in terms of the drugs which are there. And you can see from here, again, there is an antigen-presenting cell, common theme for all immune responses. And there is a CD4 T cell with the nucleus. And there is a first signal, TCR and CD3, and there's a co-signal. And then activation of T cell takes place. All those intracellular pathways are important, and we have all those different drugs which are there in the market have nothing but to stop that activation of cell or enhance that activation of cell, whichever way we want to move. So we want to direct CD4 T cell response towards our gain. And the challenge is the cancer will direct CD4 T cell towards its gain. So that's the fight that we have to put up with. Okay? But you can see pretty much the same theme. We want to block first signal, we want to block second signal, we want to block intracellular pathways all the way from cytoplasm to the transcription factor, and from transcription factor to the nuclear events, and then from nuclear events to the signal in terms of production of proteins. Now, if you pay attention, this is a important thing, that the tissue that gives rise to most common cancer in USA, and again, you will see a little bit of difference between male and female, but breast cancer remains #1 in females, but you have other cancers like skin, kidney, colon, ovary, and uterus. Whereas in men, you also have lung. Lung is common, pancreas, bladder, prostate, rectum, and bone marrow. So these are some of the common cancers that we normally see. Now, another thing you want to look at this, you will see that they're all tissues, and tissues are composed of cells. Okay. If I was to ask you, what is the common theme among all these tissues that you think could be a possible cause of cancer? What is it that you see a common theme among the tissues which are having a high level of cancer in terms of predisposition? So can somebody come up with an idea what is a common theme among these tissues? Why do these tissues have cancers more than others? Say it again? They secrete glands, or they secrete secretion? Glands secrete secretions. There's no such thing as secreting gland. Sorry? Endothelium. Did you say that? Correct. Because the most important thing is that you have to remember that they all have an epithelium and endothelium. Okay? And what is the quality of epithelium? What is the basic quality of epithelium? It tends to regenerate. Okay? It tends to regenerate. So the things are, when it tends to regenerate and it wants to reproduce the cells of the same kind, things can go wrong. So that's the basis of understanding. Things can go wrong when the cells are reproducing. And you can see from here, there's a lot of reproduction taking place in terms of cell regeneration in breast tissue. Skin, obviously, too much turnover. Colon, too much turnover. And ovary, too much turnover, because a lot of eggs have been produced. Uterus, again, monthly cycles, hormonal effects, so on and so forth. So these tissues have epithelium that basically has a high turnover in terms of cell division. And when cell divides, things can go wrong, right? So there's always a possibility that me and you would think, what are the chances of me having a cancer, for example? You can go and do genetic analysis. But one thing you have to keep in mind is that since we all have cells which are dividing, there are ample chances of us having a cancer. Or, let me put it in another way, that there always are cancers developing in us. There always are cancers developing in us, and who takes care of that? Your immune cells. Simple as that. So that's what we call immunosurveillance. So that's why if you remember, if you have deficiency in your immune system, the immunodeficiency, you are prone to not only autoimmunity, but you are prone to cancers as well. Okay, so that's the basic theme you have to understand, that your immune cells, like the one I just showed you a video about, they are killing cancer cells as they are produced. So what's going to happen is, firstly, they need to detect the cells, normal versus abnormal, self versus non-self. And they have the whole equipment, but again, things can fail. Okay? Does that make sense? Okay. Now, concept slide, and I'm going to spend a little bit of time on that. So you can see, this is an epithelium. That's what you just told me, that since they have epithelium, endothelium, the chances are the epithelium is regenerating. There are chances that cells may come up with a change. There's always a chance of any cell to mutate. But we have an intact system in our body where we check our mutations. Right? Now, you can see from here, these are normal epithelial cells, but all of a sudden, a tumor arises in one of these. And if a tumor is localized, it hasn't spread, we call cancer in situ. And we talk about that in pap smear and things of the cancer of the cervix and so on and so forth. But the thing is that if you can detect that earlier, the better it is. So you can see there are cells of surveillance. CD4 T cell will come, CD8 T cell will come, gamma delta T cell will come. Does anybody remember what are these gamma delta T cells? Sorry? Antibodies? Cells cannot be antibodies. They are T cells. Say it again. I didn't get that. Well, they are in mucosa. Correct. They are in gut mucosa, including small intestines. Most of the CD4 T cells are alpha beta. Alpha beta. Okay? But you can see they will come and have a look at it. And they would take care of it. Okay? They have this system to take care of it. But the problem is, for example, if this tumor cell become variant, this means variancy comes when the cells in the cancer are more than one type. So you can see if there are more than one type, so some of the cells would not identify them. They will go away. And if you have more variancy in terms of mutation of cells, then you lose many other cells. So you basically are left with only one cell type. Once you have a variance which is really out of control, then none of these basic immune cells will come and even look at that cancer cell. The only cell that will come over here is T regulatory cells. Can somebody guess what would that be? Is it advantageous for us or disadvantageous for us? What is the role of Tregs? Sorry? It inhibits CD8. Well, it's an inhibitory cell as a whole, not necessarily CD8. But you will see over here, and what is happening over here is that T regulatory cells are the major suppressor cells. So they basically control the whole show. Like if you have orchestra, you see this one guy with the sticks, he's kind of leading that. So that leader is Treg. So what happens is the cancers are smart. So they will have Tregs on their side. So Tregs comes on their side. So they basically will lose the whole immune response. Okay? So this is one of the mechanisms. But you can see from here that cancer cells evade, we call it evasion, evade the immune systems. Okay. The concept you have to have is that if you have to have an immune response to a tumor cell, so all the tumor cells will express an antigen. Okay? And this antigen basically is called tumor antigen. The other name for that is tumor-specific transplantation antigen, TSTAs. Okay? Most of the time, we do see that. And that's important. Because remember, if that antigen is there, and this antigen circulates in the blood, so we can detect that you have a cancer. Or if that cancer is there on the breast tissue, we can do a tissue biopsy, cut it up, and stain it to figure out what kind of cancer do you have. So antigens are there basically to mark that something is going wrong, as you saw in the previous slide. Okay? Now, also keep in mind that, as I just told you, that the chances are that all of us develop cancer over our lifespan, but we have a good immunosurveillance by both cells of innate and adaptive immune response that includes every cell, you name it, and the cell is a part of that, right? And that takes care of it and tries its best to destroy tumor cells. But again, that mechanism may not be enough because, of course, people have problem with the cancer. So let's see where are these tumor antigens coming from. Also keep in mind, one of the things that I told you that when cells are dividing and they are going through the growth phase, so that growth may be altered. So you go for different type of G1, G2, G3, G4 phases of the growth. So the growth can arrest, growth can stop. So there are different mechanisms when the cell grows. And you also saw when we said B cell or T cell or myeloid cell, they all went through a series of steps. So that step can jeopardize, and then again we may have a problem. The other thing you remember when I told you that there is in T cell production as well as antibody production, I told you that they have a very specific cell. Specificity is important. So they can generate different kind of T cells, different kind of antibody because of the genes, because of the mutation, because of many different things. So the same thing that was helpful for you to generate a specific antibody for a specific microorganism or a specific T cell to take care for a specific bacteria virus, the same mechanism can mutate and cause cancer as well. Because it already has this capability to mutate, it can activate the gene, it can cause clonal amplification. So there has been a lot of work done on picking up right from the beginning, do you have tumor antigens? That's why some of the tests are done. Pap smear is done normally, right? And above 25, if you are sexually active, they want to do it every year because they want to see how does your epithelium look like. So they want to detect that earlier so they can intervene earlier. If they detect it later, then it's going to spread. So there are some antigens. So they will take that pap smear, scrap part of your cervix, and put it on the slide, and then put an antibody on top of it and tell you if the tumor-specific antigens are present or not. And they, for prostatic cancer as well, above 40, they will always look for PSA. They'll always look for alkaline phosphatase and many other tumor markers. Now, antigens per se follow the same rule. Remember when we talked about this earlier, they have to be immunogenic, pretty much the same thing because T cells are like that, antigen-presenting cells are like that. Okay? But remember, it says immunogenic antigens. What it means are immunogenic tumors, those cancers that will call your immune system to pick up a fight with them. And your immune system should respond. But also keep in mind, there may be some cancers which evade that for their own benefit. They don't pick up a fight and then fool your immune system and cause the damage. But we are interested to figure out what are immunogenic tumor antigens and what are non-immunogenic antigens, which would not provoke our immune system, but most of them are like self-antigen, or you may have developed some kind of a tolerance to that. You look at them, you ignore them. So that, again, is an important thing. And there are tons of them. There are tons of them. And as we advance, we find out, but I'm just going to give you some of the examples because they are unique, they're common, they're part of many a diagnostic test that we normally run at a particular age. So you can see from here, since our cells are normally reproducing, and this reproduction of cells is under gene control, so some of normal cellular gene products may cause cancer. Okay? In this case, you can see they can come from embryo, they can be embryonic origin, or they can come differentiation when a particular cell, like for example, a naive CD4 T cell or naive TH cell differentiate into TH1, TH2. So that kind of differentiation can lead to a cancer if things are not under control. Or when you have a clonal amplification, for example, you give a T cell a command that you need to multiply. So that multiplicative process where cell is dividing over and over, things can go wrong and cause cancer. So these are normal. So this is something which is normally happening every time in our body. Okay? Now you can see from here, so most important are called oncofecal antigens. These are oncofecal antigens and they are known. The most famous that you will see is CEA, carcinoembryonic antigen. And that basically is a cause of lung, pancreas, breast, colon, and stomach cancers. The biggest cancer I just mentioned. So what they will do is that they will run that test for you and see if you have that tumor-specific antigen. Not necessarily that you may have a cancer, but they will keep a watch on it. Make sense? Okay. Then AFP is important because of liver melanoma, carcinoma. So for example, if a person has a family history of melanoma, a father or mother or anybody has melanoma, the chances are that you may or may not have it. So So what we need to do is that we need to check for this antigen in your circulation. That's what we do. Alphafetoprotein. Then there are differentiation enzymes and oncoproteins that you can see. The most important is oncoprotein, which is called HER2 neu, which is the cause of breast and ovary cancer. That's what, for example, if you have a family history of breast cancer and you want to find out do you carry the risk of having a breast cancer, they will run this antigen on you. Or if you do develop some kind of early dysplasia, when the first sign of cells going out of the way, we call dysplasia before it becomes metaplasia, there's a pure cancer. So we run that and find out whether you have it or not. And then again, you can see clonal amplification, which is an antibody, causal lymphoma. Then there are mutant cellular gene products. There are always point mutations occurring. If you remember a little bit of genetics, we'll think that point mutation when the gene transcription takes place. So those point mutations can also lead to many different cancers. The most important that you will see is P53, which is a suppressor gene product. Because when your cells are dividing, so they have some specific genes, either they will activate like RAG or they will suppress. So they want to make control of how the proteins are made. One of the important antigens over here is P53. That's a cause of several cancer, right? Now, having said that, the other important thing that may cause cancer, and I'll discuss that in detail in virology, is viral infection. So viral infection can cause disease. So you can see from here, if a person is suffering from HPV, it's not mandatory right now, but HPV vaccination is there for all boys as well as girls, available, Gardasil and many others, because there is a very, very high incidence of people having HPV infection. And HPV infection is #1 cause of cervical cancer of the uterus. Okay, so that again is a nuclear protein which basically comes when a virus enters into your cell and transform your gene. We'll discuss that in detail when I talk of viral pathophysiology. So that's something that viruses do. But some of them are known. For example, hepatitis B virus is known to cause hepatic cancer. Okay? AIDS virus is known to cause Kaposi cancer, sarcoma. Likewise, HPV, human papilloma virus, is known to cause, and this is pretty recent, I would say in the last 10 years. Previously, people used to say that nobody used to believe that, but now they have an evidence. To such an extent that they think more than 90% of population, for example, US population, is HPV positive. More than 90% of 90 pop is positive. So it doesn't even take into account whether you are sexually active or not. Right? So the chances are, so then the government needs to think. So when they think, they will say, okay, let's make that HPV protective vaccine mandatory. They haven't made it mandatory, but it's available for every teenage boy and girl, whether they are or not sexually active, they should get HPV because of the high incidence. Initially, they used to think only for girls because of cervical cancer, but now they are thinking, no, it's also for prostatic cancer, urothelial cancer, and many other cancers in male as well. But the point I'm trying to kind of impress upon is that cancers are coming from viral infection as well, and HPV is one of those infections that is becoming a very, very important these days. Okay, right. So recap of what I just said. Embryonic, melanoma is important. Carcinoembryonic antigen, CEA, alpha-fetoprotein are important. Differentiation, I just told you, HER2 for breast cancer, and clonal amplification, I just told you, because if these cells are dividing over and over again, they may cause. Now, when it comes to mutant cellular gene products, so we have point mutations occurring normally. We have oncogene products And some of the antigens are the result of somatic mutation. Remember, somatic mutation was something good. We thought is important, so you can produce more antibodies, you can produce more T cells with a very specific epitope. But the same mechanism, which causes genetic diversity, can also cause problems. So you may have cancers, for example, chronic myelogenous leukemia. You can have a deficiency of some of the proteins or overexpression of these proteins, and they will cause a problem. As far as viral gene products, I just told you, HPV is the major cause of cervical cancer. And this is something that, if I remember correctly, I would say maybe like less than 10 years ago, there was, I think, a German group or a European group that discovered that, and they were given a Nobel Prize for that. So it's really a topic that's under discussion. Okay, now we know for sure that tumor antigens, because they are coded, so they have a code there. So we need to pick up that code. We need to pick up the code. What is it that is there on the cancer which will lead to cancer, right? So we are interested in pointing out what are genes there. So we want to even go before that and find out what are we. This is something we call oncogenes, genes that are going to give you cancer. And some of the are proto-oncogenes, even a step earlier than that. So there's a predisposition on you that you may go in that direction. Okay? So the point that is important is that there's always an surveillance going on in your body. There's always an immunosurveillance, and immune system is looking at it, and it sometimes reacts or it doesn't react, but we all know that if there is a primary immunodeficiency, then your whole system may fail to recognize and even present that antigen, especially if you have immunodeficiencies. Okay? Now, also remember the term when we use malignant as compared to benign. That's something we discussed in pathophysiology. Benign, malignant. Both are cancerous. If cancer means an overgrowth, a tumor growth, it could be treatable or untreatable. So let's talk of malignant, for example. So you can see some of them are coming, especially those people who have immunodeficiencies. So if a person has a primary immunodeficiency, right, and on top of that, he has viral infection, so double whammy. You have a immunodeficiency to begin with, and of course, if you have immunodeficiency, you're prone to infections. So you will have a high incidence of hepatocellular carcinoma and B-cell lymphoma. If you have a secondary immunodeficiency, it could be a drug-induced, because some of the drugs can induce immunodeficiencies. Then you may have, all these viruses, but common theme you will see hepatitis B virus, Epstein-Barr virus, human papilloma virus. So these viruses are notorious because they have been linked to cancer. And a serious, kind of a discussion needs to take place. What do we need to do? And then, of course, AIDS virus, which is a retrovirus. So retrovirus basically will also lead to quite a few cancer because AIDS people, not only they have a virus, which is human HIV virus, immunodeficiency virus. It is called human deficiency virus. But it also will lower your immune system, and you are predisposed to quite a few infections or even cancers because your immune system is not doing what it's supposed to do. Okay? Now let's talk about what are the effector mechanisms? What are the mechanisms in your body that basically are geared in protecting you from a specific cancer? And when that particular component or immune response is not there, you are vulnerable to cancer. So now you can see from here, these are different components that we've been discussing over and over again. We discussed about antibodies and B cell, we talked about T cell, NK cell, LAC cell, macrophages, cytokines. So all of these basically are the players of the immune system, and each one of them have a very specific purpose. But if there is a problem with that, right? So you may have a net result effect of that. So you can see, for example, if you have a problem, and some of them are still under discussion, some of them are still in research, and there is information there, but of course we don't want to talk about that right now because it's going to expand unnecessarily. So T cells, basically, they are critical for rejection of virtually and chemically induced tumors. So they are must if you have to have that. Because remember, sometimes people in like Hiroshima and Nagasaki, atomic bomb, after that they all develop cancers because radiation causes cancer. Radiation can, and even in, I don't know, it was in Ukraine or somewhere else, there was a leak of radioactivity. Even now, that area high predisposition to blood cancer. So radiation is there, but you have to have a patent T cell. If you have problem with NK cell, you get these type of tumors. If you have lax cells, macrophages, each one of them has a role to play. So whole your innate adaptive immune system, you name, even complement has a role to play. All of them together work in a very synchronous way to protect you from cancer. So this means that if your immune system has problem, it's going to lead to many things. And cancer is one of them. So you don't want a compromise on our immune system. So that's why the typical term immunosurveillance comes from. Your immune system is looking for any oddity, anything which is unfamiliar, anything which is non-self, anything which is not normal. Okay? Now, let's kind of go a little bit more pictorial view. There are three phases of cancer immunoediting, elimination, and equilibrium escape. Because things, of course, we are learning from these patients are not that simple as we teach. So they are very, very complicated. The system is more complicated than we think it is. So you can see from here, there is a normal cell. So this is your normal cell, your skin. Let's say skin. Normal skin, happy skin, everything's okay. But they are carcinogens. You are exposing your skin to carcinogens, may it be in anything that you apply on the skin, or radiation, or there's a chronic inflammation, or you inherited a skin condition, or you have a viral infection. Some of the causes that may disrupt normality. And what will happen is, the other example says you have a low level of P53, which is tumor suppressor gene. So your problem is that your tumor suppressor gene is low. So you have high kind of prevalence in terms of getting... So what will happen is that these cells would not be normal and you will have these tumor cells. And tumor cells are then also will play some of the tumor antigens. Okay? And these antigens, of course, need to be seen by your immune system. Right? And these antigens can be shut off in your blood as well, and we can pick it up in your blood when we run a cancer test on you, right? But this cell is going to go out of control, so you'll see a little bit of swelling on that. Like, for example, melanoma, they say by the time you notice a melanoma, it has already spread in your body and pretty much killed you. So that's so dangerous. And especially, I mean, you can notice melanoma on the visible part, on the front. What about back? Right. So there are many things that are important, especially when it comes to skin care. So you can see from here, 3 steps: elimination, equilibrium, escape. So let's say your immune system is good, you have a very good cancer immunosurveillance, and your cells of innate adaptive immunity all just jump in onto cancer. Your T cell, macrophages, gamma delta, NK cell, they secrete what they need to secrete. They totally get rid of the cancer and you are protected. Right? So this is their job. They pretty much eliminated that without you even knowing it. Okay? The other thing is that what may happen is that if you may have some of the problems, like for example, there is a genetic instability, or your genes don't make the right choices, or they are designed in a way that they have a predisposition to particular type of cancer, like a history of melanoma, a history of breast cancer, whatever. So this case, you may not generate a profound immune response, and then you basically are in a situation half and half. So maybe your system, normal system can overcome, or your cancer can overcome. So you just are struggling in between. If we diagnose you at that time, we can intervene and we can help you out to remove the cancer, chemotherapy, radiotherapy, whatever we want to give. But if that system escapes, for example, if that system escapes, one of the mechanism escape, I told you that T regulatory cells, which should work for you, they are employed by cancer. Some of our smart cancers. So what they do is they will take on their side. We're still figuring out how can they take Tregs on their side. So if you take Treg on your side, Treg is going to put a brake on CD8, is going to put a brake on many cells, and it will let your immune system know that I'm in charge, everything is okay, don't worry. Right? And then, again, you will have escape of immune system and have a full-blown cancer. Okay? Now I have a video, but this is another important thing you can see from here. This is scanning electron micrograph, where is an activated macrophage, and it has all those receptors, and this is going to kill 3 melanoma cells. So it may seem to you that those receptors are not there, or maybe, but they are real. Right? And this is what we need. We need our macrophages to be equipped with those, and we can do so. That's what treatment is all about. Okay? Kiss of death, we talked about that, and you saw that in video as well. The cancer cell has T cell will go and kill it. Now, there are tons of cytokines in the whole system. If there is a deficiency, of course, you will have a compromised immune response. So cytokines and cells are such that we can play with. So if we find out this is what your immune system is going towards, we can intervene and help you out. Okay. Now also remember, that immune system basically has a role to play, of course, but most of the immunologists think that even if you have best of all the immune systems, normal immune system, still you may not be able to completely eliminate cancers, right? So we have seen that happening. The reason is some of the tumors escape. So we need to find out what are the mechanisms where tumors escape immune system. That's another important aspect, and I want you to know, and I'm very fond of that question. So just bear with me. This is how, there are two types. One is tumor-related, and one is host-related. So you may have a problem, or tumor may be over-smart. So in this case, you can see is that the failure of tumor to provide a suitable antigen target. So that is a protective mechanism, that the tumor does not provide you with an antigen. And remember, as a rule, if there is no antigen, immune system is helpless. If your antigen-presenting cells are not getting what they need to get, T cell is blind. T cell will never see this antigen on their own. They have a presentation, unless you have cytolytic T cell. That's kind of an exception. It doesn't need any specificity and doesn't need that kind of signal. So you can see from here, they may have lack of antigen epitope, lack of MSC class 1, deficient antigen presenting, antigen modulation, masking, and so forth. So you can see some of the tumor comes with all these mechanisms, and they would not, even if there is an antigen, they will come and down-regulate your MSC, so you cannot present their antigen to invite T cell help. So it's like pretty smart mechanism for the tumor cells. Or they do, let's say they recognize, but that immune response is not sufficient enough. Even if it's not that smart, but not sufficient enough, because there's a lack of antigen epitope, there's a decreased MSC, and they can also block co-stimulatory signals. Some of the tumors would do that. They know that you need 2 signals for T cell activation. So okay, let it be that you go through the first signal and then block the second signal. Okay? As a matter of fact, I was preparing for this lecture this morning, and I said, okay, there was one co-stimulatory molecule that I didn't talk about, PD, and that turns out to be the last year in December 2014 as the major player, where they found out that if you can block that, you pretty much can take control of the cancer. So that was considered as one of the most important as of December last year. So some things are coming up which are there in terms of receptors and we ourselves are unfamiliar with, or maybe we didn't pay much attention that we should have paid. As far as host is concerned, of course, if you have problem with your immune suppression, if you have deficient presentation, if you have a failure of host, so you can see from here, many things which are there on your part, you're not smart enough, your immune system is weak, is deficient. And one of the important things that I've tried to talk about in quite a few, I said that Tregs are taken by the cancers on their part. So you'll see that over here, Tregs hindrance of tumor immunity. Tregs should work for you. We still, well, we know the mechanism. The cancers will go and buy our cells on to work for them. Simple as that. And then we have a problem. Okay? If you were to put the whole scenario I just mentioned in this table on a figure, so you can see from here mechanism by which tumors avoid immune recognitions, because you know for sure unless they are recognized they would not be killed. So you can see that they have low immunogenicity. So these are the things when the tumors, for example, have low immunogenicity, they don't present any peptide, they don't present any adhesion molecule, they don't present any co-stimulatory molecule, so nothing will happen. Or they are smart enough that they come in a disguise and they camouflage themselves and they put on your clothes. So your immune system thinks, no, this is self. It's not self. So they kind of are smart. So tumor treated as self-antigen. If they are treated as self-antigen, there's nothing you can do. Okay? Then they can also antigenic modulation. So they have antigens, but they modulate their antigens in such a way that these antigens attach to antibodies and then they basically are phagocytosed. So these antigens never get a chance to be presented to T cells. That's another, and all cancers are different. Then again, tumor-induced immune suppression. So tumor itself comes in your system and it suppresses your immune system. When it suppresses your immune system, it weakens your immune system, and this is how it does. So you can TGF-beta, they release TGF-beta, or they basically can inhibit T cell directly, or they induce regulatory T cell by tumors. So tumor themselves bring in suppressor cells. So these suppressor cells will dampen the immune system. So that's another mechanism that the tumors do. And these are some of the basic mechanisms. And then again, some of the tumors basically secrete some factors that will cover them up. So they have this protective covering from outside, and then they are not seen. So you'll go over there disguised. There's nothing to be seen. So they would kind of draw that barrier, a physical barrier. Immune cells will come for surveillance. They won't see anything, and the tumors can do what they want to do. Okay? Now, our goal, basically, we want to diagnose these tumors. So we are looking at the antigens. That's what the most important thing is, right? We're looking at some of the malignancies that are very specific antigens. That's the major struggle. That's the major research in cancer today. That you, as we discussed earlier, some of the proteins, some of the other things that are known, alpha-fetoprotein, these are some of the earlier signs of developing cancer. So they have norm value. If all of a sudden they find out a person such and such an age has an elevated level of alpha-fetoprotein, then they will be worried because they are high in liver cancer, ovarian cancer, testicle cancer, so on and so forth. So these are not only immunodiagnostic markers, but they are also markers for your treatment as well. So if you're treating cancer, their level should go down. Okay? And there are many ways, we discussed that earlier, that you can detect. And for each and every cancer, I mean, I don't want to go in detail, but what you need to know is either there's a specific antibody for that particular antigen of the tumor, or there are some of the tumor antigens that have been shed off. So this basically is immunodiagnosis. For immunoprophylaxis, so what we need to do to protect? Well, once we know the cause, we know HPV is a cause for cervical cancer in women, so we will protect you by giving you vaccine against HPV, or hepatitis B virus, or any other thing that we find out. So that's like immunoprophylaxis, we can do that. When immunotherapy, then again, there are a lot of different things that we can do and help, right? But the problem is right now we are still struggling because whatever we find out, the cancer outsmart us. They are ahead of us, right? So we really have to struggle. But what I would do is for the last slide for you to think at least for this part of the lecture based upon your very basic knowledge of immunology, that pay attention to this slide. And you can see if this happens to be a tumor cell, okay, and then again, this is going to present this antigen. These antigens are going to be recognized. So we have a whole immune system around a tumor cell which will work around to get rid of that, right? And sometime you can see from here, we can come up with an anti-tumor antibody. Maybe we can come up with another anti-tumor antibody. Some of the fusion proteins. There are many different options that we have. One of the things that we are doing these days is that we're coming up with dendritic cell vaccines. So we pretty much take dendritic cell from you, prepare it for whatever we need to prepare for, and then put it back. So we basically, you can see over here, cDNA coding for tumor production in expression vector. There's a very complicated technique, but this is the future of vaccination, where we would take cell out of your body, treat that cell in a way that it needs to be treated, and put it back. Right? So these are some of the things which are coming up for cancer immunotherapy. But again, as I said, that I would really want you to get the sense of it, that why things go out of control. But again, if you really want to understand, I think prerequisite or requirement for that will be basic genetics and basic cell biology. And then again, I didn't actually took it out some of the slides for the anti-cancer drugs, because there's no point me asking you, but you know where those antibodies, those cytokines and things of that sort are going to act. Okay?